So if you do that, you can just kind of move that skin back. And if you're entering down this way, you can move the skin, you can get a little bit more lateral, more on the outside of where you're entering, and then move that skin back towards the center because you're coming down and out again. So that then at that point, you get the slack and you can get full depth into the actual muscle tissue without being restricted from the connective tissue in the skin. One of the best places to release is where the muscle meets the tendon. And on the iliacus, the tendon is very broad and flat at the superior part of it, where it attaches into the iliac crest. So you can kind of get right on the top part of the iliac crest where you feel the bone with your knuckle or with the tips of your fingers, and you can get right there and kind of bend it and strip through it. Same kind of thing here with the rocking technique. Now there's not going to be the same amount of movement here as you could get once the muscle releases, simply because it's very fixed here where I am. It's very tendinous. Part I was in earlier should move in the same way that you might see the bicep move, because the bicep is a long muscle, right? So it can move like this once it's nice and loose. But the iliacus would be more like the deltoid, even less than the deltoid, but for lack of a better example, it's a shorter muscle and it doesn't have the same movement, so you can't get it to move quite as far. It's the same kind of thing when you're working on the iliacus and iliopsoas there. So then moving on, once that's released, I'd continue to kind of move the pelvis at the ASIS to put the pelvis in a bit of a better position passively. And I can also test here as well. I can come back and say, okay, if that was effective, is the pelvis sitting in a better position? Is this ASIS higher up? And it is. That's in a better position. It's not completely where I'd like it to be. There's other structures involved. Like I said, the quadriceps, both deep and superficial. Some of the adductor muscles, the pectineus, which is an often overlooked muscle that goes from the pubic bone into the femur and can cause that rotation, that specific rotation. So all structures should be addressed. And again, that's the beauty of the exercises, is you can address all the muscles if you know what position to put the body in, all at the same time. With the massage, with the manual therapy, you have to get into each one specifically and make sure nothing's overlooked. But if you can get the body into full, specific functional positions, you know that as long as the range and the joints are proper and the positions are proper, then the muscles are allowing for that movement. So as stated before, where the muscles join the tendons is one of the best places to apply pressure and release. So as I come down here into the quadricep attaches into the ASIS here, the pointy part of the pelvis, and then it runs down into the knee. So I want to come to where it starts to meet that patellar tendon, and that's another really good spot to just give sustained pressure to get that tension taken off of that muscle, and then thus off of the functional hip rotation there. And again, this can be a painful technique sometimes, so you have to work within your patient's threshold. If I felt too much resistance from Mark, like even, there's a lot of people that have a very high pain tolerance, and that high pain tolerance is just more mental than anything else. So they might accept the pain, but the muscles don't. They fight against it. So if I added pressure and Mark starts to contract the quad too much, and he says, oh, you're fine, add as much as you need to, but the quad is pushing my knuckles out, the technique's not as effective. Now you have two options at that point. You can overpower his muscle, which is effective. If you have the strength and stamina to do that, that'll work too. Or you can just let up to the point where he doesn't give you that resistance, your patient doesn't give you that resistance, but you're still able to apply enough pressure to get the result that you want. Now as I move down much closer towards his kneecap, I come back onto that tendon. Now I'm on mostly tendon here. There's very little muscle here. And I add pressure and I move that tendon towards the midline of his body. Now this technique is called a GTO release. So the tendons have these sensors, for lack of a better word, in them. Golgi tendon organs are called. And they respond to being manipulated. So when they feel like they're under tension, they let go a little bit, which lets the rest of the tissue, the rest of the muscle let go as well. So you can twist, you can bow, you can push. It all gives you that same effect. You can get into a little bit of IT band as well as you continue with that. So now I'm kind of following the quads up. I'm more lateral in the quads now, more into the vastus lateralis muscle of the quad. Again, quadriceps, quad, four muscles. You have your rectus femoris, the one in the middle. You have your vastus lateralis, a lateral one. You have your intermedius, and you have your medius. All should be addressed. But primarily, number one, rectus femoris, and then depending on their overall position, you can kind of deduce from there which ones are causing more of the imbalance, but again, they should all be addressed. So before I turn Mark over and have him work more specifically on his back, one of the things that I like to do for the hip, a lot of times the lower back pain can be accompanied by hip pain also. And even if it's not, when the psoas and the quads are causing that compression, the hip gets locked up, even if you don't feel it so much, you're not aware of it. So after we did all that soft tissue work in the hip, in the muscles that cross the hip, I like to come and take the patient's leg, get him into a nice loose open position, which is just a little bit of abduction away from the body. And then I pull inferiorly, and then if I feel movement, sometimes I have to go out a little bit further, and I kind of look and feel at the same time how much downward movement am I getting. Generally, 6 inches or so of abduction is the ideal position to get the hip joint in an open pack position. And so from there, you can do a little bit of joint play inferiorly, meaning that you're bringing that joint into an inferior direction, into a lower direction. And then when I feel the full tension, like I can't bring Mark's hip anymore, I think about pulling his body a few inches down the table. And that gives a final bit of space in the hip joint. So from there, might just go. Sometimes there'll be a cavitation, meaning that an audible pop, like a chiropractic adjustment kind of thing. That's what a cavitation is. It's the pressure change in the joints and the air being released. So sometimes you hear that in the hip, sometimes not. The next thing I do, just gonna move the camera a bit, is, as I mentioned before, everything starts from the hands and feet, depending on what's going on. So the feet dictate the knee and dictate the hip, etc. So I would never work on a lower back or a hip issue and just ignore the feet entirely and stick to those areas. I'd come all the way down to the feet and see what's going on here. And often if there's any dysfunction in the feet, it can lead to compression in the ankle. So I'd address the ankle joint and just create a bit of space in there. Is there any pain with that, Mark?
A little bit, yeah.
Okay. And what you have to watch for, though, with the ankles is a lot of people have hypermobile ankles because they've sprained their ankles here and there. And you want to be pretty gentle with those techniques and gradually create more space instead of like a quick technique unless you really know what you're doing. So if you're ready, Mark, you can go ahead and have you turn over onto your stomach. So in a full-length massage session, it would be a matter of getting as much of the soft tissue released as possible, and then getting into some of the more functional whole body stuff. But because Mark is having pain in his lower back, I'd spend a lot of time specifically in those muscles, not because that's the most effective way to treat it as a whole, but because that's where he's feeling it. And if we reduce that tension and get better movement, we can get to the more functional methods of treatment from there. There's definitely nothing to lose. So again, continuing to go with the idea of creating space in the joints and increasing that lordosis. I might add a little bit of pressure to the lower ribs, and then again that whole fascial chain goes into the calves, so I do a bit of a spread coming down, moving those two apart. If I come to his ankle, I get better leverage and I can adjust my hip position so I can kind of lunge forward from here, pull that leg down, and then once that leg is pinned, I switch positions, keep the heel of my palm here, and then just lean forward across his body, and then that forces me to bear my weight in my hands like a wide push-up position, and in doing that it spreads apart the lower back into the hip and up through the ribs. And if they're really tight in the calf and in the Achilles, they might feel a bit of a stretch while doing this too. Not necessarily really tight, but some tightness. You might feel it. Some people feel it there, some people don't. And then I might continue up that chain doing various techniques to the hamstrings, to the glutes, and just loosening up the soft tissue that has been used to being under tension for too long. And if it fights you too much, if you feel those muscles contracting, just ease off and find that happy medium, what the patient can tolerate and what you know is going to make change. The same rule applies here. When you feel a spot that's quite tight or shortened, you can stay there, you can add a bit of movement to it, and when that muscle starts to move, that tendon or muscle starts to move more independently from the rest of the body, you know that it's starting to let go. Doing okay, Mark?
Definitely feeling.
Sorry?
Definitely feeling that.
Yeah. Is the pressure okay?
Yes.
Okay. So moving on, I keep the heel of my hand on his ribs And I get a lot of leverage by putting my forearm against his sacrum and the posterior part of his pelvis as well. And what you want to do is kind of feel it with the bone and then transition this way, because otherwise I'm putting too much pressure on his bone with my bone and it really doesn't feel good. There we go. So I just wanted to create a bit of space in the SI joint, a bit of space in the lumbar spine. And then I get more specifically to the vertebra. And similar in the sense of like what with a muscle where you're kind of pushing back and forth until it moves independently from itself. There's much less movement in the actual vertebrae, but we can get the same idea where we just kind of push it in one direction. And then if it starts to move more independently of the rest of the vertebra, then that's good. Motion is lotion. It applies to both manual techniques and exercise-based movement. And from here too, I can diagnose, well, I don't know if I'd use the word diagnose because that's kind of a protected word, but you can make it an informed clinical impression about what might be going on as you palpate this area based on the tissue feel, like the movement that I'm feeling, but also especially based on the feedback from your patients. So if I suspect that Mark has a little bit of a herniation in his disc, for example, if I go in between those vertebrae and in between each intervertebral joint, add a bit of pressure, I can potentially feel a change. But more importantly, if I press and he goes, "Ow!" or something like that, gives me a strong reaction, then I know that there's likely a bit of a herniation going on. It would be an informed clinical impression, not a diagnosis, that there's a herniation going on. And of course, you could at that point get a proper diagnosis, and there's nothing wrong with that. It's always a good idea, but that involves, of course, going and getting X-rays or MRIs and having a doctor say this is what it is. But if we think that it's likely the case, we can put the body into positions that are optimal and do techniques that will that have very low to no risk of harm anyways, and high chances of putting the structures in a position that allow the body to heal. So whether it's a validated diagnosis or not, the most indicative thing is the results. Is that feeling better? Are we making progress? And then you always want to have variations in the technique. So go from different angles, different pressures, different depths. Just like with functional exercise, variation is key. Specific but varied. So the next thing I'll do with Mark's lower back here while he's in this position is address the more superficial connective tissue. So I do what's called rolling, fascial rolling. So when the back gets tight, the superficial fascia gets tight, it can pull on some of those structures, and you can release that. So what you do is you kind of pick up the skin, and you can just go straight up, and oftentimes you get a cavitation out of that, again an audible release. And you just kind of roll and go up and do the same thing. You don't always get that cavitation. Sometimes it takes a few sessions. Sometimes it just takes a few times in a session. If your patient experiences too much pain doing that, then obviously ease up. There's one there. So he's getting those cavitations a little bit higher in the lumbar spine. Or that one anyways. There we go. There's another. How's that feel?
Good.
I think we're maxed out there. So the other thing that I've noticed in the past with Mark is that with the functional discrepancies with the muscles, what can happen?
Hello.
Hey, how's it going, man?
Am I allowed in here?
Yeah, we're filming, but yeah.
So sorry.
No, it's all good. So with the functional discrepancies of the muscles, what can happen is that they want to take over in different movements. So with Mark, his left side likes to take over more than it should. So if I ask Mark, can you bring both hands in front of your head and then lift them up towards the ceiling, kind of as high as you can? So actually it's looking okay right now, but let's try it unilaterally. So go ahead, relax your arms. Just do that with the right arm. Reach as far above your head as you can, like towards the wall. Yeah. And now lift up towards the ceiling. Okay, and then do the same on the other side. So yeah, I'm still seeing the left side kick in a little bit more than I'd like to, but right now it's actually looking pretty okay. But for the sake of this video, what this technique is if he lifts both or one side arm up and we see rotation coming in the pelvis where the erectors on the side want to do everything, we want to take those out of action so that we can get these guys to work. And if I remember correctly, Mark, you had pain that kind of went along here before. Is that right, or was it the other side?
Left side, lower down.
Left side, lower down, yeah. Yeah, so what we might do there is come to where we feel tension in the muscle or come to part of the tendon. I like to use my elbow, but you can use knuckles or fingers depending on the situation, and kind of find that muscle where it's kicking into overdrive, and then ask your patient, okay, go ahead, raise your arms again. Now, I feel like I'm not quite on the best spot, but again, just for the sake of the technique demonstration, you can apply pressure to stop that muscle that you don't want to over-contract from contracting.
Right there, you got it.
I got it? Cool. And so then the other muscles start to kick in, and that allows you to work within balance. And oftentimes this can be enough to take the pain away, and it can be sustainable because it's just training the nervous system once again, training this muscle to let go and the other muscles to kick in where they should. Especially for acute, when people are in acute pain, that's one of the better techniques to do. Get them out of it quickly. Okay. Now I do feel, just based on what I can tell from the